Okay, so coming to the clinical features, right? uh, Clinical features that we'll be seeing in a case of neonatal jaundice, right? The first and the foremost thing is icterus. Icterus is what we see, right? And we have to remember that icterus has a cephalocaudal progression, right? So it will start from the face and then it will move down towards the limbs, right? So let us draw a diagram which is called, which is based on the modified Cramer's rule, right? So modified Cramer's rule. So we'll be drawing a diagram and then we'll be seeing how to calculate the estimate the amount of bilirubin that might be circulating in the blood, right? So let us draw right. So in this diagram, let me explain things to you. So the first is face. The first part to develop icterus is the face, right? So in face, if there is presence of icterus, so it will contribute to around 4 to 6 milligram per deciliter, right? At the hemoglobin level, sorry, bilirubin level of 4 to 6 milligram per deciliter, the face will develop icterus. Then comes the chest and upper abdomen, right? This part comes the chest and the upper abdomen, right? So I'll write it down: chest and upper abdomen. So it will be 6 to 8 milligram per deciliter, right? Then we have this lower abdomen and thigh. Lower abdomen and thigh. This lower abdomen and thigh, lower abdo plus thigh, it will be 8 to 12 milligram per deciliter, right? And when it involves the arms, right? Arms of the upper limb and the lower limb, right? When it involves the arm of the upper limb and lower limb, arms and legs, right? It is 12 to nearly 14 milligram per deciliter. And finally, when the soles and palm, right, sole and palm gets involved, it becomes more than 14 milligram per deciliter, and this is very severe condition, right? 14, not really, 15 we can say. So this is the modified Cramer's rule. So we saw if it is face, then it is 4 to 6 milligram per deciliter. Then comes to chest and upper abdomen 6 to 8, lower abdomen and thigh 8 to 12, and the arms and leg 12 to 14. More than 15 comes the palm and soles, right? So other methods with which we can see the amount of bilirubin are the transcutaneous bilirubinometer, transcutaneous bilirubinometer, right? Or direct, we can take the blood sample. This is what we do generally, blood sample, and we do screen the blood, right? Now it was the clinical feature icterus that we saw in the patient of hyperbilirubinemia. The patient can develop neurological symptoms as well, right? Certain neurological symptoms Neurological symptoms that can include, to understand the neurological symptom, the raised amount of bilirubin, it most commonly involves the basal ganglia, right? It most commonly involves the basal ganglia part, right? So when the basal ganglia is involved, so it shows extra pyramidal type of cerebral palsy, right? Now there is a thing called kernicterus, right? Kernicterus, right? So kernicterus basically means yellowish staining of basal ganglia, right? When the basal ganglia gets stained yellow, it is called kernicterus. Now in bilirubin encephalopathy, there can be two forms. The first is called, the first one is called, the first is called acute bilirubin encephalopathy, right? The first is called acute bilirubin encephalopathy, and there are early features and then there are late features. See, from the early features the patient progresses to the late features. So early features generally are seen are the that we see. First is hypotonia, right? Hypotonia develops, the patient starts feeding poor feeding, and a very important thing to remember is there is loss of Moro reflex, right? Moro's reflex gets lost, which later on progresses to fever, irritability, and seizures, right? It starts with hypotonia, poor feeding, loss of Moro's reflex, fever, irritability, seizures, which then progresses to a more severe form, right? This is severe. This is a severe form or advanced form, late stage, right? Where there is development of hypertonia, right? The patient becomes opisthotonous, and the person further lands up in coma and ultimately death. So this is the stage of uh, acute bilirubin encephalopathy, acute bilirubin encephalopathy, where there is early and late features. Early features are mild, late features are severe, right? There is hypotonia, here there is hypertonia, right? Because of hypertonia the patient develops opisthotonous posture, which later on lands the patient in coma and further in death, right? So now coming to the next thing, that is chronic bilirubin encephalopathy. Chronic bilirubin encephalopathy, right? Chronic bilirubin encephalopathy. So what happens in chronic bilirubin encephalopathy? Just remember, because the baby is chronically hyperbil, the mom gets sad, right? Sad mom. Okay. So SADMU, right? S stands for SNHL, sensory neural hearing loss. A for athetosis, right? D for dental dysplasia. M stands for mental retardation, and U stands for upward gaze limitation, right? U stands for upward gaze limitation. So these are all the clinical features that we see in a patient with uh, uh, neonatal jaundice. So the clinically we will be seeing icterus and the neurological features that may come up with high bilirubin concentration. There is kernicterus, staining of basal ganglia leading to extrapyramidal type of cerebral palsy, leading to lots of um, early and then chronic stages of diseases, right? So now let's talk about the treatment, right? So treatment of neonatal jaundice. How do we treat a case of neonatal jaundice? The first uh, thing that comes in the treatment of neonatal jaundice is, of course, phototherapy, right? Phototherapy is what we use. The second thing that can come in our mind is exchange transfusion, and the third things are certain drugs, right? So we'll talk a bit in detail about phototherapy, but let's talk about this exchange transfusion and drugs before we go with phototherapy. In exchange transfusion, it is used in very severe cases of neonatal jaundice, like the erythroblastosis fetalis, where there is, severe jaundice, severe hemolysis leading to very high amount of jaundice in the patient. So what we do is that we do double volume exchange transfusion. In this exchange transfusion, so that we take out the blood from the body of the child, and then we try to make it as free from the hemolyzed RBCs as we can, right? And the drugs that is also most commonly used in case of erythroblastosis fetalis is the IV IG, right? Immunoglobulin is what we try to give. What happens is that normally in erythroblastosis fetalis, what happens? The RBC are coated with maternal antibody, right? The RBC, they are coated with the maternal antibody, right? Antibody is coated over the fetal RBC, and then it goes to the spleen, right, where it binds with the FC receptor of the spleen, right, and it gets hemolyzed, so leading to high amount of bilirubin, right? So what this IVIG is doing is that it binds to the FC receptor. It actually binds to this FC receptor here. It binds here, and then it prevents the spleen from identifying this antibody coated fetal RBC, so thereby preventing its hemolysis, right? This is how it works. So in a case of severe neonatal jaundice, right, with erythroblastosis fetalis, how would you treat it? So we generally start it by treating with phototherapy, right, and it keeps on continuing. Along with that, we do exchange transfusion, and the IG treatment goes along with it, but the phototherapy is the mainstay of treatment in case of neonatal jaundice. So let us coming to the phototherapy. Some points regarding phototherapy which will help us understand how it works, right? The most effective wavelength that is used in phototherapy is 450 to 470 nanometer, right? 450 to 470 nanometer, it is the most effective wavelength that is used. Coming to some other facts, how phototherapy works, quite oftenly asked in the viva. So let us talk about it. Mechanism. So there are basically three mechanisms with which it works. Let's name it, right? The first is photoisomerization. photoisomerization. The second is structural isomerization, and the third one is photo oxidation, right? Photo isomerization, structural isomerization, and photo oxidation. Photo isomerization, okay, photo isomerization is a technique in which the bilirubin gets converted into a polar compound, right? Polar compound which gets excreted through the kidney. But the thing is that this photoisomerization technique, it is slow and reversible, right? The main technique that we use, the most important one, is the structural isomerization, right? What we do in this, the bilirubin gets converted into lumirubin, right? It is a polar compound which gets excreted via kidney, right? But this very conversion is irreversible, right? And this process is fast. So majority of the conversion takes place by the uh, mechanism of structural isomerization, and then there is photo oxidation, which is least important. We are not really concerned about that. Now, talking about the effectiveness of phototherapy depends on, what it depends on is important, but what it does not depend on is rather more important. So first thing is the exposed surface area of the baby. The more the baby is exposed, the better it will work, right? The second thing is distance between the baby and the phototherapy unit, right? Distance between the baby and the phototherapy unit, there's distance, and the most appropriate distance between the phototherapy unit and baby, right? The most appropriate distance is about 30 to 45 centimeters. 15 सेंटीमीटर का 3 स्केल, राइट? 3 से 4 स्केल, जस्ट दिस इज हाउ आई हैव tried to remember it. And the third one is the type of lamp type. Most of the time earlier it was CFL, right? But now the LED, we all know that LED are better than CFL. So LED, what it does not depend on is more important. Like I said, it does not depend on the skin pigment of the baby, right? Color of baby, it does not depend on this, right? And irradiance, it should be at least for 30 microwatt per centimeter square per nanometer. If you can remember it well and good, I just remember 30, right? And it is measured by using a flux meter. Okay, so now that we have given the phototherapy, let's talk about some of the adverse effect of phototherapy. Adverse effect includes Brown's baby syndrome or diarrhea, right? Dehydration, hypocalcemia, retinal toxicity, and gonadal toxicity. And of course there is impaired maternal and child bonding. Now if you have seen the patient who are given phototherapy and are kept in the ward, their eyes and gonads are covered to prevent retinal and gonadal toxicity, right? So there is one more drug that is also used. It is Barbiton, right? Phenobarbital is the drug. It induces the UDP glucuronide transferase. It increases the activity of glucuronide transferase. So it is generally used in Krigler Nazar syndrome, right? So these are the things that we have to keep in mind regarding the neonatal jaundice. Uh, okay, the credits I've taken, whatsoever I've written are mainly from the notes of Dr. Minakshi Bothra ma'am. Uh, Thank you.